Good evening, everyone. Thank you for joining us and spending part of your evening learning about camera and how it can help patients in your own practice. We're really excited tonight to spend some time talking about the latest in caries science and research. Before we get started, just a few housekeeping items. First, you are all muted, so we cannot hear any comments or questions verbally. Please make sure to type questions into the questions box at the right-hand side of your screen. At the end of the presentation, we'll have about 15 minutes to answer questions. We will do our best to get through as many as possible. Any questions that we don't have time for will be addressed by email, and we also offer one-on-one webinars for practices interested in learning more. So with that, I would like to go ahead and introduce Dr. Kim Kutsch, CEO and founder of Oral Biotech and the Carifree system. Dr. Kutsch has been successfully practicing dentistry for over 35 years, still practicing 3 days a week here in Albany, Oregon. He has a huge vision for curing dental caries, motivating him to start this company. And it continues to motivate him in the research he's leading to improve caries diagnosis and treatment. He has a lot of passion for what he does, and it's always great to hear him speak. So with that, Dr. Kutsch, take it away.
Hey, thank you, Janelle, and welcome everybody tonight. I do have a huge passion for what I do, and this is my favorite topic of all, dental caries science. I'm like a little kid at Christmas. So this is kind of my favorite webinar that I get to do every year. And actually, it's appearing that it's like your favorite webinar as well. Looks like we've almost set a record here with attendees. And so that's a compliment to you all that have tuned in here tonight and your passion for dental caries as well. I start these kind of things, and I think it's like, well, I feel kind of like Sheldon Cooper, Fun with Flags. You know, who's going to watch this? But you guys have kind of blown me away. So we got the message loud and clear. I will do this every year for you. This has been one of our most popular webinars, and so we're going to go through the last year of dental caries research, and I think that you'll find tonight pretty interesting. One thing I did want to share is for any educators that are on tonight, and I know we typically get quite a number of dental educators, if you would like a copy of my PowerPoint, you're welcome to it. If you want to use these studies in some of your programs or in your classes in the dental schools, you are totally welcome to it. All you have to do is email me or just contact Carifree, and we'll get you a copy of those to use as you wish. So with that, let's get started. Untreated tooth decay or cavities and permanent teeth, also known as dental caries, is the #1 disease of 291 recognized major diseases by the Global Burden of Disease Study. It affects 35% of the world population, and if you dig down into the data, dental caries is #1 in every country pretty much in the world in terms of diseases, and it's pretty much #1 in every age group in each country. So you know, the frustrating thing for me is, 35 years ago when I started doing this, I was told to make sure I, was successful early in my career, because by the time I got to this point, there wouldn't be cavities because of fluoride, and I'd be doing something different because we wouldn't need dentists, and and here we are, and this disease is #1 in the world, and it's growing, and so we obviously have new challenges today, and the whole point of this webinar tonight is to let's try and understand this disease better, and that's what really motivated me 15 years ago. Try and learn more about this so we can be more effective for our patients. So we got the most common disease in the world that we're dealing with. It's a complicated disease. It's complex. I can't name a more complex biofilm disease in the human body. And so the fact that we're frustrated or that we're dealing with bacteria that continue to adapt and change to our strategies, shouldn't come as a surprise to us. And the more we learn about the bacteria and how they interact with each other and the nature of this disease, it becomes more and more complicated. And I look back at some of my early lectures, 15 years ago on dental caries, and it was, our understanding of dental caries has grown a lot in the last 15 years. The problem is, we're not getting more effective at treating it, as a profession, and so we really need to dig down into this and try and understand more. One of the things that I came up with a few years ago is, rather than make this thing too complicated, genius is always in trying to be able to simplify something so that we can digest it and take it and get our brain around it, so we can actually take it to our practice and put it in place with our patients and make it effective for them. So one of the things I came up with was The Usual Suspects. I love this movie. But, instead of looking at 50 different factors, the pattern recognition that I see typically with these high caries patients that I see in my practice, they either come in with bacterial issues. I had one of those today right before I came over here tonight. High bacterial score, no other real issues that I could identify. So it's really, he's got the wrong bacteria and they're behaving badly. It's diet typically is one of the major issues, one of the usual suspects. And the patterns that I see there, patients either eating too much simple sugar in their diet or they're eating too frequently. And, with the Stefan curve, that creates a problem. Saliva is like nature's way of protecting the teeth. And so you start taking medications or have any other issues that reduce your salivary flow, and suddenly you've tipped the scales and, you're out of balance, and that's a recipe for a problem as well. And a couple of years ago, I added this one, genetics. We'll go through a couple of additional genetic studies as well tonight, but the more that we learn about, studying our genome, the more that we learn that there's probably a lot of, and I mean very diverse different factors that can influence this disease. But at the end of the day, it always comes back to Kaiser-Sose. It's really a disease driven by pH. So it's really, if you can come up with these patterns and start to recognize these patterns with your patients, it gets easier and easier to know where to start to counsel the patient or to do the wellness coaching with them and where you're going to move with treatment on that. When we look at bacteria, the most I put together the list of, again, in the last year, there's over 50 bacteria now that have been identified as potential cariogenic bacteria pathogens. The most recent one was this last year, Propionibacteria acidifaciens from Dinah Wolf and her group in Germany. And we'll talk about that study here tonight in a little bit. Diet, certainly, that's an issue. Americans eat 23 teaspoons of sugar per person per day. It's probably one of the reasons that we have the obesity issues that we have in the United States, heart disease, hypertension, et cetera, and high fructose corn syrup. While the studies are pretty clear that high fructose corn syrup doesn't really contribute to dental caries, certainly not like sucrose or glucose. We're the #1 consumers at 51 pounds per year. By the way, Mexico is #2 at a distant 32 pounds per year. So certainly the high fructose corn syrup, we introduced it into our diet in the 1980-81, and that's created some real havoc for us here in the U.S. This came from the Mayo Clinic this last June. 70% of Americans now take at least one prescription medication every day. We are a prescription drug pharmaceutical-based society here. More than 50% take 2 or more, and 25% take 5 or more prescription medications every day. There were 4 billion prescriptions written last year alone. So you start compounding. I know you see this with your patients. We got our seniors that are taking 10, 12, 15 prescription medications per day. The #1 side effect from those drugs is hyposalivation or xerostomia. And again, you take away nature's mechanism to protect the teeth, and you have any other little factor out of balance, and you've got a real recipe for disaster. And actually, I just saw this patient right before I came over here today. It's been a year we've been treating her, managing her bacterial levels, and finally have her healthy and she's stable. And so we restored those mandibular incisors this afternoon. But we're looking at genetics, and suddenly we have studies that that look at a variety of different sources that appear to have an influence on dental caries. So, there's a hereditary component there. So I want to do 2 things tonight. I want to talk about the biofilm model. I just want to update for you, that if you haven't seen it. I'll give you a quick update on, really how we look at dental caries today. And then I want to go through about 30-some studies that have been published in the last 12 months in the U.S. and abroad, and talk about the clinical applications of practicality, or what does that mean for us clinically as we try and deal with this disease. So starting with the biofilm model, this really hasn't changed for me a lot in the last year. We certainly know that we have multiple pathogens play a role. It's definitely a biofilm disease. We know that there are potential systemic effects. I haven't seen a lot of research on systemic issues in the last year or two, but certainly in the last 5 or 6 years, there's been quite a bit of research on that. And it's not shouldn't be surprising to us that bacteria in the mouth, enter the bloodstream, enter the body, and create complications other places. Just getting a report, I'll be getting a report from the biofilm research up at Montana State, looking at which bacteria are found in the body on different implants and problems. And I'm betting that a bunch of those are going to be oral bacteria. If from origin, and a number of those may be pathogens that we consider, to play a role in dental caries. And then we've got those hereditary components that we just spoke about. So that's really what the biofilm disease looks like. This paper was published right at the end of 2012, and in this study they looked at, it was a 20-week in situ study on using 8 different individuals, and they took restored and unrestored dentin and enamel sections, and they just looked at the shift in the bacteria on the plaque as it matured over a period of 20 weeks. They compared 1 week and 20 weeks, and there was a microbial shift. They used denaturing gradient gel electrophoresis in that, and what they came up with was Rothia dentacariosa and Scardovia inopinata were absent from all the Carifree site, but appeared in 50% of the Caries active sites. So Rothia dentacariosa and Scardovia inopinata were added to that list of potential cariogenic pathogens. Again, we just continue to see a broader spectrum of bacteria playing a role here, and we're going to get into that whole model in a little deeper here in a little bit. This was Diana Wolf's study that was published last January, February in the first journal of Caries Research 2013. And in this study, they took 26 young adults that had severe dental caries, and they had 28 that were, caries-free. And they did a panel, a checkerboard looking at 43 DNA identification of 43 different bacteria. And what they found was that the one within this cohort, the one bacteria that was significantly associated with dental caries and not with the caries-free individuals was the Propionibacteria acidifaciens. And so, again, we just continue to add, the more studies like this that are done, the greater diversity that we see in different bacteria that play a role. So the old Mutant streptococci lactobacillus, those are still players, they're still in the game, but they're surrounded by a broad team, and I think I really don't see this whole thing slowing down. I think we're going to continue to identify more and more bacteria in the biofilm that play a role in dental caries as time goes by. So Propionibacterium acidifaciens is the latest. This came out from Nakano's group in Tokyo. This was 300 random specimens taken out of the coronary arteries and off the heart valves during open heart surgery in the OR in Tokyo. And what they found was that the number one bacteria, when it was found in the mouth, it was found 78% of the time on the heart valves and in the coronary arteries, was strep mutans. And their conclusion, actually, in this study, they did a series of about 3 papers, and this one was published in 2009, but their conclusion was that actually strep mutans and AA are related to are probably the cause of most bacteremias and maybe an etiologic factor in the development of cardiovascular disease. So I think we need to see a lot more research in this field, but I personally wouldn't be shocked to learn that cardiovascular disease is more bacterial in origin than it is from cholesterol level, let's say. So that really wouldn't surprise me, and I think it's probably too early to make those kind of claims, but I'm just saying if and when we get to the point that if that becomes our understanding, that wouldn't surprise me at all based on, how we look at how many bacteria we have in the body and how they do very good things for us and at the same time can be very harmful for us. We know that strep mutans, this study from 2011, has a CNM gene that allows it to actually directly invade endothelial cells. So you get these, strep mutans circulating, and they're on the heart valve or on the coronary artery, and they can actually invade the endothelial cell directly. So it gives them a real pathogenic mechanism to get inside of these cells in our arteries. So certainly I think that's a concern, and an understanding that, that I think carries some weight as we start to think about how these bacteria play a role in our systemic issues. This is one of the first studies that was published, and this came from 2010 in the Journal of Dental Research, and they took 300 individuals and they looked for the polymorphisms of beta defensin 1, which I think that you've probably all seen this study if you've seen me lecture in the last 2 or 3 years. But they took 300 individuals, they collected saliva samples, they looked at the 3 different polymorphisms for beta defensin 1, and beta defensin 1 is a salivary protective enzyme, and so it's primarily a defensive enzyme that's found in the saliva. And they found that the individuals that carried the G20A copy had DMFS and DMFT scores that were 5 times higher than the people that had the other variants, and the G52A polymorphism was associated with lower DMFT scores. And so there was significance in that level. And when you get to a level of, this is 5 times, when I read this paper, it was like, wow, there's definitely an issue going on there. You don't see odds ratios of 5 very often in research. So that was one of our first attempts, and of course this was followed up. We know that we have these kids that are known as super tasters. It's from the TAS2R38 gene and the TAS1R2 sweet gene for Caries for taste, and we know that these are affected or have an impact and carries risk for children. We know that the TAS2R38 gene tends to lose its expression somewhere in the 40s as people age. So people at midlife, they hate it. They're particularly sensitive to phenols. So green vegetables, Brussels sprouts, broccoli. If you have a child or know a child that's a super taster, these kids literally just can't tolerate these foods, and so they prefer sweets at that age as well, and so that may increase their caries risk. As they get older, as adults, they may find that they actually like these vegetables that they couldn't tolerate as children. So it's kind of an interesting study, but that was published. This one was published right at toward the end of 2012, and this is in the dentin, the matrix metalloproteinase 13. So these are enzymes that actually participate in breaking down the protein in the dentin. So as dentin, as digester breaks down, particularly like in a dental caries process, you have these proteinases that are in there that affect that. We've looked at their effect on the degradation of bond with resin to dentin bonding, the impact that they have, and so we're trying to retard the MMPs using a variety of things, chlorhexidine and what have you. But this was an interesting study. They had took 505 individuals, 212 of them were caries free, and they looked at their caries rates and they compared then their polymorphism for the MMP13. And what they found was that the people that had a mutant variant of the MMP13 actually reduced their risk for dental caries. So they had a lower caries rate. So it appeared that if your MMP13 wasn't as effective as an enzyme at breaking down protein, it seemed to reduce your risk for dental caries, which I thought was very interesting. This study published again at the very end of 2012. This study looked at the human leukocyte allele, DQ12. They took 164 individuals in this study. They were aged 15 to 19, and they examined them for polymorphisms for this human leukocyte allele, and they compared that to their DMFT scores. And what they found was that, again, the adolescents that were positive for this HLA DQ2 were less likely to have dental caries. So, we started looking at these different genetic sources, and it's like, you look at salivary protective enzymes. Well, that makes a lot of sense, right? And I think you look at that and think, yeah, okay, I get that. Taste, okay, yeah, that makes a lot of sense. They prefer sweets over green vegetables. Yeah, that makes sense to me. And then you start looking at things like, the matrix metalloproteinases, and then you look at human leukocyte antigen, and on the white blood cells, and you think, wow, this just gets more and more complex as you think of the different factors and the different, I guess, approaches that influence dental caries. So it's kind of, I included this study. I think it's pretty interesting. I think we've got a lot to learn. And then this study was published this last year, just a year ago in January, Schaefer and Feingold, and they did a genome-wide association study. They took 920 adults, basically from the age of 18 to 75. They looked at 518,000 gene sites, and then they compared basically the caries rates of these individuals, and they tried to look for, and they identified about 10 different major gene associations that had an increased risk demonstrated an increased risk for dental caries. Some of them, we understand. Some of them, I read the research, we look at it, and they say it has some effect, We have no idea what this gene does, but we know that there's a significant relationship between this gene and the risk for dental caries in these individuals. The other thing that they did that was very interesting was they took all of this data and when they looked at it, it had a geographic distribution or expression in the mouth. And they found basically 5 different expressions of dental caries based on geography of where the decay was found in the mouth. And I've talked about this before. This patient particularly was referred to me by a local pediatric dentist, and she's only ever had decay in her mandibular incisors. And going through this process and interviewing the mother and talking about it, this actually is a positive sign for a deficiency of lysol 2, which again is a bacteriolytic enzyme in the saliva. And lysol 2, if you think about the mandibular incisors, those are the last men standing in this disease. Those are the last 6 teeth. If somebody has 6 teeth, that's who they are. If they only have 2 teeth, you know which ones they are, right? And they have the most saliva. They're bathed in saliva. They're the most protected teeth in the mouth. So for you to see, when I read this study, I thought, okay, well, I've never seen that. That really doesn't, it just doesn't ring true for me, because those are the last 6 men standing. And to see decay in only those 6 teeth, not sure I'd ever really seen that. I've seen it twice now in the last year. I just didn't recognize the pattern. And when I saw this patient, I just read the study, and I looked at the mom, and I went, she has a lysol 2 deficiency. And, she looked at me like, how could you possibly, she didn't even know what that was, and how could you know it? But it's clear, it's identified, based on this research. So I think that it's very interesting looking at the geography and realizing that if you have only decay in your maxillary incisors, or if you only have decay in your mandibular premolars, that this could be a genetic issue. So I found this paper extremely interesting just from the standpoint of these were patterns that I hadn't recognized previously. And they didn't really make sense for me. And then when I read the research and I started seeing the patterns, it was kind of like a light came on. So I thought it was a very, very interesting study, and I think you're going to see them follow up with a number of papers in this whole research. But looking at the entire genome, and then here was a patient, the AJAPI gene possibly involved in tooth development. This patient came to me again, referred to me. She is 15 years old, and she has 17 crowns and 2 root canals. She's 15, and she has 17 crowns and 2 root canals. And I went through, her mouth was pretty clean. I went through all of the risk factors, and I couldn't come up with anything. I mean, I sat there with her mother, and we went and looked and talked about diet, and we looked at saliva. She had plenty of saliva, and I went through all the stuff, and it's like, and has anybody ever talked to you about what was causing this? And, of course, she'd been like, I'm the 4th dentist now on the line, and she needs 4 more crowns right now. Has anybody talked to you about this? And I think it may be genetic, and it may be possible with this AJP1 gene. So it's like you start to look at things, and if you don't have any other explanations and you look at the risk factors and you're not coming up with anything, I mean, keep asking questions. But, when I saw a patient who's 15 years old and has 17 crowns and 2 root canals, that's shocking for me. And, that should be shocking for any dentist that sees a patient like this. And we got to sit down and start asking questions and try and get to the bottom of this. So, all of this is going to come out of the genome-wide association studies. And on that topic, Lizzie Buchan, who writes, one of the editors and publishes a lot in Nature magazine, came up with a real interesting theory a couple of years ago, and that was that we should stop looking at biofilms as a collection or a community of all these individual bacteria and start to look at biofilms as a superorganism, because a biofilm really behaves as a single organism, like this superorganism that has all of these different functions. And they trade DNA. They share DNA. I mean, they not even have to be the same species, and they share genes back and forth through their cell walls. If you have one bacterium in a biofilm that has a resistance to an antimicrobial agent, within 30 minutes, every bacteria in the biofilm is resistant. So it's amazing the capacity that these bacteria have to adapt and change. And we need to start worrying about exactly, after I talk about all these new bacteria we've identified, we really need to stop worrying about which exact bacteria are there. We need to start looking at it as a biofilm, as an organism, as a whole. And that brings up a paper that was published last year that I think really This is really a landmark paper, and again, it's Takahashi and Nebad. They've published 3 papers in the last 6 years that I think are really profound in terms of how they're directing or changing the direction of our research and our I guess our understanding of this disease. And their whole point is, yeah, we agree with Lizzie Buchan. We need to stop worrying about which bacteria are present. We need to start worrying about what the biofilm is doing. And we need to know which genes are present. Is a gene present, and is it an activated gene that's creating a metabolic function, in the case of dental caries, that has an output of creating acid? And if that gene is present and it's functioning and it's producing acid, we've got a problem. We've got dental caries. And it doesn't matter which bacteria, possess that gene and contributed it to the biofilm. We just need to know. We need to start looking at output and looking at our genomic studies rather than trying to identify is strep mutans there, in what number, although we get a good correlation in children between strep mutans and their decay rate. We really need to start worrying about what's really happening with the biofilm. And I think that'll get us closer to being able to deal with this disease. In the case of dental caries, we're talking about pH, and we're talking about acid output. And of course, that plays right into the, my whole, I guess, understanding of dental caries in terms of being a pH-driven disease, and maybe we should, use some pH strategies to treat it with as well. So that kind of gives you an update on the biofilm, model as I see it today. Let's start looking at some of the research that occurred here in the last 12 months. I included this study because I thought it was quite interesting. This came up in JATA back in October, and I read this, and I can tell you the first time in my first dental company 20 years ago that I approached a researcher at a major dental university, and I was working on trying to create the ramp mechanism for curing lights. And we were writing the algorithm, and all I wanted to know was I wanted them to test it, and I wanted to know if my algorithm was correct. And if it wasn't, I wanted to correct it so it actually matched the polymerization cycle of composites. And the answer was, well, what would you like the outcome to be? What would you like the conclusion or the basis of the study, the results to be? And I said, I'm not looking for a particular result. I just want to know. I want to know what the actual algorithm, do I match it? If not, I need to change it. And I think that a lot of our scientific research that's university-based has maybe been contaminated a little bit in the last 20 years. If there's any researchers on here tonight, this is probably heresy. But I think that, certainly, I'm CEO of a company, and, we have to always be cognizant of the fact that you have a conflict of interest. And if you're trying to look at research, we know that the people doing the research influence the outcome based on their expectation. And if you also have a financial conflict of interest at the same time, I think we need to be aware of that. Anyway, I just thought it was a very interesting paper that, finally it's like the forbidden topic, but finally I think, let's have permission to talk about that. As we evaluate some of these RCTs, if there are people that have if it's funded by a company, maybe we need to look twice at that. So anyway, I just brought that to your attention. If you want to read it, I think it's an interesting article. This I thought was an interesting study. This again was published in JATA back in January. I think one of the questions I have is, does crowding influence the risk for dental caries? And this actually looked at a number of papers. It was a systematic review and meta-analysis, and I looked at papers from 1960 to 2011, and it ended up including only 8 cross-sectional studies. But the results of this was the data was just all over the board. Some studies said it slightly increased the risk. Some of them said it moderately decreased the risk. So that at the end of the day, there was just no random controlled trials or studies that confirm or refute an association between crowding of the teeth and dental caries. So I think, I just thought that was an interesting study, and I thought I wanted to include that for you tonight. So no influence, as far as we can tell, based on this systematic review. This was another paper that I included, and it's really about lesions, and I thought that this was an interesting one as well. And it was really based on taking a model, a simulated model of a 15-year-old patient, and looking at doing a single-stage caries removal and leaving some of the affected dentin or maybe slightly infected dentin behind, and doing a single-step restoration versus doing a 2-stage restoration where you go in and place a temporizing type material, remove all the decay, and then come back after the tooth is settled down, and then go ahead and place a permanent restoration. And despite the level of evidence, they really thought that just a single stage removal and leaving some of the decay behind actually improved the vitality of the teeth, and it was less costly and probably had a better long-term outcome. So I know that I've seen a number of studies in the last 3 or 4 years looking at specifically, and I think Edwina Kidd actually directed me to a couple of those, where you see that if it's better to leave a little decay, if you're going to have a direct pulp exposure, you're better off to leave that little bit of decay there and use some MTA or something to cover it up with, and then place your restoration than you are to go ahead and have that exposure and then increase your risk of needing to do a root canal procedure on the tooth. So I thought it was consistent with that, so I thought that was an important thing that we should kind of keep in mind. That's something I know we all have to make these kind of decisions every day in our clinical practices. So this I thought was a really, really interesting paper, and it's a theoretical paper, but they actually did, again, using DNA identification, they did kind of mapping on dental caries as the caries disease progresses and the lesion enlarges. And so while we've been aware of the fact that there's a change in the bacteria, as we look at which bacteria are present in white spot lesions, or what's present in healthy enamel in the biofilm versus a white spot lesion versus just a newly cavitated lesion versus one at the DJ versus one that's deep into the dentin, we know that there's a change in the biofilm makeup of the bacteria as that occurs. And the theory here is that it's tissue dependent. And so I thought that was really a brilliant way of putting this into words, that it's really the tissue that determines which bacteria and type of bacteria are present. If you stop and think about that for a second, enamel is different than dentin. There's a higher degree of protein in dentin than there is in enamel. Enamel is initially more susceptible to acid erosion. And so they looked at, what they did was they took these different stages of lesions and they took samples of the bacteria, they did DNA identification on them, and then they looked for the number of different bacteria that were present, or operational taxonomic units, OTUs. And what they found was that the greatest diversity was on the healthy biofilm. It only had 0.12 strep mutans in the study. There was a little over 1,000 different operational taxonomic units on the surface of a healthy biofilm on healthy enamel. As that changed and became more acidic and you ended up with a white spot lesion, the strep mutans, the strep gordonii, mitis, and sanguinis, increased, and the number of diversity in terms of different bacterial species that were present decreased dramatically, down to like 193. So this is probably the most harsh environment in the decay process. It's the most acidic, and so it really reduces the different bacteria that are present in that white spot lesion down to just strongly acid uric bacteria. But as it progresses into the dentin, then there was an increase in the number of diversity of bacteria that were present, and primarily predominated by Prevotella, which is we associate with periodontal disease. We associate on the tongue or in the gingival sulcus. So it tends to be more anaerobic, and so you look at that, okay, well, in dentin, in that part of the lesion, that makes sense to me. And strep mitis was the most predominant streptococcal species that was present. And then once you got deep into the dentin, it changed again. And there was it became more acidic, and there were fewer bacterial species again, and strep crustatus suddenly appeared. That became the predominant strep species there. And again, then you're looking at strongly acid uric bacteria that took over the biofilm there, like lactobacillus and then Candida albicans. So I thought it was really an interesting way to look at this approach, as that disease progresses as that lesion progresses into the teeth, the bacterial makeup that are present in the biofilm change, and that's driven by the tissue, and it's driven somewhat by the environment. It becomes a lot more anaerobic the deeper you get into the tooth, but it's driven really by the tissue itself. And so I thought it was just a really interesting kind of way to describe what happens as these lesions progress. And so I found that interesting. I thought it made sense, and so I thought I would share that with you. This was a systematic review, again, looking at caries prevalence, and they looked at a number of different risk assessments. And the problem is the heterogeneity of the populations and the outcome criteria. They looked at these different caries risk forms and different models and predictions, and basically, said, we need more evidence. It should be validated at least on one independent population, and on top of that, the number one predictor was the baseline decay rate. So you look at a child, and the greatest predictor for their future decay is whatever their present decay is. And that makes sense to me. If we look at periodontal disease, we know that the greatest predictor of future alveolar bone loss is their baseline alveolar bone loss today. What does today look like? And so it's not, I think, not shocking that their baseline caries prevalence turned out to be the best predictor of future decay rates. But I think, while that's well and good, I think when we look at this clinically, I still need to understand why they have the decay rate, and the risk assessment form may be not the greatest predictor of future disease, but what it does today is it tells me why they have the disease, if that makes sense to you. So it's like, while the risk assessment form may not be as great a predictor 5 years or 10 years from now of what their decay rate is going to be, actually their current decay rate is a better predictor of that. And hopefully if we intervene with more effective therapy, we can improve that outcome for the patient. But it's the whole value of the risk assessment form is not to tell me whether they're high risk or low risk. I can see if they have cavities on their teeth. The whole value of the caries risk assessment form is not to predict how many cavities you're going to have next year. The whole value of that is for me to figure out what their risk factors are, what's driving this disease, so that I can counsel and coach the patient and try and help them get healthy if that's what their goal is. So I think we get lost sometimes on trying to put too much weight on how important is the risk assessment form and how accurate it is. Well, I'll tell you what it's accurate about. It's accurate about helping you determine why the patient has a disease. And that's the most important question to ask. It's not how many cavities you have. The most important question to ask is, why do you have cavities in the first place? So anyway, next study up. This actually came out of the National University of Singapore, and they took 544 children aged 3. They followed these kids for a year, and they looked at their caries risk assessment form. They also used bacterial cultures at the same time, and so they combined the two together and came to a combined sensitivity and specificity of greater than 160%. Now, in dentistry, we don't use a lot of diagnostic tests. I mean, we just haven't done that, and so we're not really, I think, well-versed in terms of sensitivity and specificity as it comes down to diagnostic tests. The gold standard for a diagnostic test in medicine is the combined sensitivity and specificity should be greater than 160%, or 1.6, let's say, so that if you have 80% sensitivity and you have an 80% specificity, or the combined between the two is more than 160, that's kind of the gold standard, and it doesn't get a whole lot better than that. But so most of our risk assessment forms are somewhere in the 100 to 150 maybe. When you combine it for this particular risk assessment form in these early children, which we tend to get better results with than we do on adults, but it combined bacteriology with it, they actually got above the 160%, kind of that gold standard mark. And so file that one away. Risk assessment forms, we need more research. That's a valid argument. We need more science. But again, I just go back to the whole point of the risk assessment form. It's not about prediction, but it's really about finding out why. It's trying to figure out, who done it. And then this paper, Compendium, October of last year, again, it just reinforces the whole concept. We need to understand the risk factors as they contribute to the dental caries process, and then ultimately knowing these risk factors will allow us to work with the patient to reduce their risk factors where that's appropriate, and make product and behavior recommendations to the patient, and kind of help coach them through that process to get them well. So it's really about managing risk. So that's that fits into our current understanding and model. This was an interesting paper that was published in Caries Research this last year as well. We know that glucose transporter plays a role in dental caries, and so the GLUT2 gene, the glucose transporter gene, and the TAS1R2 sweet gene, which I already talked about tonight, we know that alone and in association and combination are associated with increased caries risk. And in this, they looked at 80 healthy adults. Some of them had caries, some of them were caries-free, aged 21 to 32, and they compared their genotypes or their polymorphisms basically with their DMFT scores, and both of these were associated individually and together with an increased risk for dental caries. So again, we've got, another genetic study. We'll add one more genetic study here. This is the effect of salivary carbonic anhydrase number 6. We know that carbonic anhydrase, it's an isoenzyme found in the saliva again, and it's a protective enzyme. It plays an important role in the homeostasis of the oral soft tissues. We know that it participates in the process of taste. We know that it protects the teeth against the loss of minerals and dental caries, and we know that it possibly plays a role in the formation of dental calculus for patients that have periodontal disease. So this study actually didn't attribute the carbonic anhydrase directly to dental caries. What it did was they located the CA6 gene, which was directly associated with the concentrations of the secreted carbonic anhydrase number 6 in the saliva. So, if you have poor expression, or there will be more research on this, but if you don't have enough carbonic anhydrase in your saliva, again, that's going to put you at increased risk for dental caries. And so now we know the gene responsible for that, and so we're starting to look at genetic variations on that as well. So, you start to just in your mind start to think about all the different variations of genetic expressions that are contributing to this disease, and it makes it more and more complex. But again, as I make this disease more complex for you tonight, just keep going back to the usual suspects. Just keep thinking about pattern recognition. At the end of the day, this is all about pH. This was an interesting study that was published in December in the Journal of Dental Research, and really looking at the exopolysaccharide matrix. And the matrix itself has a pathogenic role. Like, the better the development of the matrix, the better, or let's say the better the ability of the biofilm to create these heterogenicities in that space, in that three-dimensional space, and create these low pH microenvironments within it. So it's like that exopolysaccharide matrix is essential, and it's really a virulence factor in the cariogenic biofilm. And so this was, we don't often just stop and think about the matrix itself. We think about the bacteria, but the matrix plays an important role as well. So I thought this was an interesting study. And of course, the biofilm matrix is hard to break down. We know that sodium hypochlorite is one of the things that helps to break down the matrix of biofilms and dissolve that. I included this, and I included this. This is about periodontal disease, not dental caries. So you're getting a little bonus here tonight. You're getting one for the gum disease, folks. But I thought this was an interesting study because we talk about beta-defensin 1, and we talked about the genetic variations in beta-defensin 1, dating back to the 2010 study we talked about earlier. This is beta-defensin 2, and they're looking at the copy number DEF-B4 and variation V, and they looked at this with severe chronic periodontitis in patients. So they actually had a significant association. They took 136 patients that had chronic periodontal disease. They had 91 patients as controls in this study, and what they found was that if you had low levels of beta-defensin 1, copy number 4, basically increase your risk of severe chronic periodontal disease by 3-fold. So when the beta-defensin 1, the G20A group, increased their risk for dental caries by 5-fold, this increased your risk for periodontal disease by 3-fold. So as we start to look at, we're all familiar with the interleukin 1A and 1B genes that we've associated and have a strong association with periodontal disease. There could be other factors that I think we're going to see in periodontal disease as well as dental caries There could be a human leukocyte antigen. There could be, I mean, you go down the list here, the carbonic anhydrase could play a role. But now we have strong evidence that beta-defensin 2, that salivary enzyme, plays a role in periodontal disease as well. So I know I'm off topic here a little bit, but I think that you all appreciate that the more that we learn about the genetics in the mouth, the more we come to understand how it plays a role in the two biofilm diseases that we're responsible for treating, dental caries and periodontal disease. So I just wanted to share this one with you. It's a bonus for you, but I thought it was really interesting, and so I included it. Next up, I talked a little bit earlier about the matrix metalloproteinases and how they have affected the dentin resin interface. Well, one of the other things that in this study, we know that Strep mutans has esterase activities, and it has esterase activities at levels that degrade adhesives, composites, and adhesives, and also the dentin resin interface as well, and probably responsible for or plays a role in the development of secondary dental caries around some of our composite or bonded restorations. And in this study, they took 30 days. They incubated a resin dentin interface either with Mutant streptococci UA159 or an uninoculated culture medium. They compared Scotch Bond multipurpose, Easy Bond, and Z250. And the results were that it definitely degraded the Strep mutans, definitely has the ability to degrade the resin dentin interface. So again, just one for us to think about in our restorative dentistry and the importance of people having a healthy biofilm in terms of outcome and predictability of the longevity of our composite or adhesive restorations. This was a very interesting paper. It was published in January, in the first issue this year of General Dentistry, and I don't know if you had an opportunity to read this one or not, but it's a very interesting review of probiotics in dentistry, and it was very well done. I will say that the paper was very well done. To the authors, my hat's off to you. It covered a wide, broad topic of probiotics just in the body, and then looking at how we've been trying to apply probiotics, certainly in things like periodontal disease and malodor and dental caries. The only problem I have with the paper is that they only provided studies that had positive outcomes or supported probiotics, showed a positive outcome, and there's only a few really in dental caries, but there's a tremendous amount of research on probiotics that show that there isn't any net effect. And so they didn't really cover those papers in there, and and in my mind, I'm still hopefully optimistic that Svante Twetman is going to come up with an answer for us with a probiotic that's going to, be one more piece of ammunition that we've got, or one more tool that we've got to help our patients with, and specifically for certain patients as we find an indication for it. But to date, there's not an overwhelming amount of science that indicates that they work. They have short-term results, but the problem when you start to look long-term, for a probiotic to really be effective, it needs to become a permanent member of the biofilm, and that just doesn't happen. It doesn't happen in the mouth. It happens in other places of the body, certainly in the stomach and the intestines, and we've had great results with that. But in terms of dental caries and in the mouth, the minute the probiotic's gone, pretty much, the next day it's gone from the mouth. So it's a great paper. I think it's a great review. I just wish they had included some of the negative research as well, because I think it's important for us to take a balanced look. What does this really mean, and what is the real promise and outcome for probiotics? So I'm hopefully optimistic, but at the same point in time, I think we need to be honest and look at all of our research. So I'm going to give you a couple of papers that were just published recently. This one last fall in the Journal of Caries Research, and this they looked at Bifidobacterium animalis subspecies lactis BB12, and they gave it to infants from the age of 1 to 2 months. They gave it to them every day until they were 2 years old. And they got either a slowly dissolving pacifier that was inoculated with the lactis BB12 or a spoon that they sucked on. And they either were in a group that had the BB12 or they had xylitol or sorbitol. Then they looked at them again at age 4, so 2 years later, and there was no change. There was no effect from the Bifidobacterium animalis in their caries rate on the children at age 4, and there wasn't any presence of the Bifidobacterium anymore in the biofilm as well. So it was transient, and it really didn't have any effect on the caries rate. So that's a recent study. This one, another recent study. This was then in the last issue of Caries Research in December of 2013. And this was looking at Lactobacillus paracasei F19. And again, they took 179 children from 4 to 3 months, and they treated with them. This was in the cereal, and the breakfast cereal as a supplement. And so they gave it to them every day for a period of 9 months. And then they looked at them again as 9-year-olds. And it didn't establish itself in the oral microbiota in any of the subjects. So of the 179 kids, not a single one of them had this in the mouth at age 9. And there was no impact on their dental caries rate. So again, it's like, I'm optimistically hopeful that you keep looking at this research, and it continues to have kind of pretty much the same result on this. So the Lactobacillus paracasei, so file that one away. Then looking at, this was the Council on Scientific Affairs of the American Dental Association. This was published in JADA in November. Came out with fluoride recommendations for people in terms of anti-caries strategies. And nothing really new here. Per se, it's, fluoride varnish on children, that's still, and adults. We're still using fluoride varnish. Only recommending fluoride varnish for children that are 6 or younger. The other thing that they had in the study, and they dug this up, and I was kind of puzzled for a little while when they first did this, but a 0.09% fluoride rinse, which would be a prescription fluoride rinse. We typically were all using 0.05%, which is over the counter. It's easy for patients to get their hands on. And we've got a tremendous amount of research on that. We've been using it for years with success. But they went back to studies from the 1960s and the 1970s and some in the early 1980s using a 0.09% fluoride rinse. It was done in the grade schools at the time, and they were given to these kids like once every week or once every 2 weeks as a supplement for fluoride in the schools. And actually it had a very good result. But we're talking about 60-year-old research. And so I guess the thing that I struggled with personally was, we've got so much more current research. Look, going back to that, maybe they're thinking the compliance would be better if they only have to do it once a week or once every other week. But we've got so much more current research, and I had some in-depth conversations with John Featherstone, Doug Young, and we all kind of came to the conclusion we're going to stay the course with the 0.05% fluoride rinse. But it was curious to me that they brought up this older research. But I got to tell you, the research was very impressive from 50, 60 years ago. We'd just love to see current research on that. But anyway, that's a recommendation, and primarily on kids under the age of 6. The ADA's position is only fluoride varnish for children under the age of 6. Now we're going to move away from that here for a second, and because one of the other things that's been on the, it's certainly been around, not so much in the United States, but in a lot of foreign countries, is looking at low level of fluoride toothpaste. And now we're talking somewhere between 100 and 600 part per million fluoride toothpaste, specifically for children to reduce the risk of fluorosis in their permanent teeth. The levels of fluoride in toothpaste in the United States, the standard fluoride toothpaste you go buy off the shelf is 1,100 parts per million. In some countries, it's 1,450 parts per million. So the range on these toothpastes for standard fluoride toothpaste in the U.S., it's 1,100. It goes up to 1,450 in other countries. And the low fluoride toothpaste run from about 100 to 600 part per million. And, of course, then we've got the 5,000 part per million fluoride gels that we all use. Those are prescription-only products. So the low fluoride toothpaste in this study, this was actually, again, a study they looked at, a systematic review, and they looked at a bunch of different papers and found that it may reduce the fluorosis, but it increases their risk for dental caries. So, standard fluoride toothpaste can control development, but may lead to dental fluorosis. So what you have to weigh out in your mind, and I would tell you that the American Academy of Pediatric Dentistry recommends a small amount, even for young children. I'm talking age, 1, 2, and 3. If they have severe early childhood caries, the risk of fluorosis is less than the risk from having severe, or the complications of having severe early dental caries. And so they actually recommend using an 1,100 part per million toothpaste on small children, but in very limited quantities. So that's from the American Academy of Pediatric Dentistry. You have to weigh out individually, and it's a conversation maybe to have with the parent. You know, is it better to run the risk for this or that? You know, are we better to try and fight the disease or run the risk of a little fluorosis? The other thing, this was the next paper published again. This was in Caries research this last fall, looking at the same topic. They looked at 1,932 individual charts of children from the age of 2 to 5. They included 159 articles. They did a systematic review and a meta-analysis, and there was no evidence to support the use of low fluoride toothpaste by preschoolers regarding fluorosis prevention. So again, we're back to the ADA doesn't recommend it, the APD does, and the research is mixed, and so it's a conversation I think that individually you need to have with the parent if you're going to recommend that. Certainly if I have a child that's 3 years old and has severe early childhood caries, I'm going to tell the parent to use a standard 1,100 part per million fluoride toothpaste or dentifrice in a very small amount, like half the size of a pea to brush on their teeth, but also be aware of the fact that we run the risk of fluorosis in some of their permanent teeth. This was an interesting study. It was published. Comes out of Denmark, and they looked at 176 elderly disabled nursing home residents in 6 different nursing homes in Denmark. And it's interesting because I have a friend in a nursing home that I'm seeing right at the moment that's having dental issues, and the staff at the nursing home he's in won't help him at all. They won't help him brush his teeth. They won't. He has a partial denture. They won't brush it for him. They won't literally provide any dental oral hygiene care whatsoever. And so it was interesting to me. In Denmark, they have the staff brushing their teeth twice a day, and they did this in this study for 8 months with either a 5,000 part per million or a 1,450 part per million fluoride toothpaste. And the mean number of active root caries lesions at the follow-up examination at the end of 8 months, in the 5,000 part per million group, they only had 1 active root caries lesion versus 2.55 in the low-level fluoride or standard level fluoride. And the number of arrested caries lesions were 2.13 in the 5,000 part per million group, and they were only 0.61 in the 450 part per million fluoride group. So the outcome here is 5,000 part per million fluoride gel is significantly more effective at reducing dental caries on root surfaces in elderly patients that have a lot of exposed roots, both for arresting lesions and also preventing lesions than a standard fluoride toothpaste. And that should come as a shock, but we have data to certainly support that now. Trimetaphosphate, they took in this study, trimetaphosphate is a form of, again, phosphate, and certainly enamel is calcium phosphate, carbonated calcium phosphate. So we look at 88 bovine enamel blocks. They treated with a placebo, either with 100 or 225 micrograms of fluoride per milliliter. The rinses that had 100 micrograms of fluoride per milliliter had 6 different concentrations of trimetaphosphate from 0 to 0.6%. The blocks were then subjected to a pH cycling for 5 days, and they were treated twice a day with one of the mouth rinses. After that, the surfaces were cross-sectioned, and they were tested for hardness as well as the presence of fluoride in the enamel. And what they found was that it actually, having the fluoride rinse with 100 micrograms with the addition of trimetaphosphate actually was superior in inhibiting enamel demineralization compared to the mouth rinses that did not have it. So again, having some of these either some form of calcium phosphate or hydroxyapatite in some of our strategic, products that we're going to use with patients, certainly we need more research, but certainly I think that's a good strategy. I included this study from Caries research, and it really pointed out that we really need to start talking about behavioral changes, that one of those patterns up there that we see of this disease is we're talking about diet, which is a behavior, bacterial load, which is a behavior, and so we really need to start talking about and getting better in our research at looking at behavioral change and behavioral change practices and educating ourselves as a profession. And so really this to me comes down to wellness coaching, and that's a topic I've been talking about here for the last couple of years. But I really, this is going to be one last piece of the puzzle for us when we've got everything else in place. We still need to be able to work with the patient and have the skills to be able to talk about, how do we help coach that patient through making a behavior change, one change at a time. This is sweetened beverages, sugar-sweetened beverages. We all recognize the issue there. And in this study, it's really just a paper looking at behaviors, attitudes toward frequency and duration of sugar-sweetened beverages, which is a huge problem for us in the United States. And I know that you guys all see that every day. I had 2 high Caries patients this week that their main risk factor is Gatorade. So that's, and of course I've talked earlier also not only just the sugar-sweetened beverages, but also pH, and we'll talk about that again here in just a second. I thought this was a very interesting study. It came from the World Health Organization guidelines, and they looked at, it was a systematic review of 5,900 papers. They included 55. 3 of them were intervention studies, 8 cohort studies, 20 population study, and 24 cross-sectional studies. And what they found was that there was a moderate quality of evidence showing that the Caries rate is reduced when their free sugar is in their diet is reduced to less than 10% of their dietary energy. And with a 5% dietary energy cutoff, there was a significant relationship. But the evidence was judged to be of low quality. So obviously we know there's a connection between sugar and dental caries. It makes sense to reduce that. We have some science, but looking at all of it, it's a low quality of evidence, basically. I've talked for the last year or so about, the pH of beverages, and the shocking thing for me was, the pH of bottled water. And, this was in the AGD impact in January of this year, excuse me here. But I think it was a really good chart, I think for patients. I'm going to use this with patients, just looking at, what are you drinking, during the day? Tap water, we need to make this tap water is 7.0 or 7.15 in that neighborhood. Bottled water, we know that half the bottled waters have a pH of 4.0. So we really need to be clear with our patients. It's great to drink water. Make sure you're drinking one that is not acidic. Anyway, so that was just a great graphic. I wanted to share that with you. This was an interesting study, and we get these studies out of China, and it's always interesting to me because I know that they do some of these studies of researchers actually sniffing a patient's breath to figure out whether they have bad breath and rating them on a scale of 1 to 3. Here they actually also measured the level of hydrogen sulfide with an instrument that was coming off of the tongue. But they did this over a period of 3 days. They took 29 adults, Chinese adults, and then they found, and the interesting thing here was then they did bacterial DNA analysis of the tongue. They did DNA mapping of the tongue, and then started to look at the mapping for the bacteria that were associated with severe malodor or bad breath. And they found that Leptotrichia and Prevotella, again, Prevotella comes up here. That was the deep carious lesion bacteria. Prevotella comes up as being positively correlated with malodor. And Haemophilus and Gamella, garden variety bacteria of the mouth, healthy bacteria exhibited a negative relationship with oral malodor. The poor research assistant is sitting there having to breathe people's bad breath and trying to score whatever they were being paid that day. It was not enough, I can tell you that. This is a study I just found about 2 weeks ago. I thought this was very interesting. It was looking at the association between head and neck squamous cell carcinoma and dental caries. And we know that there's in dental caries, we know that cariogenic bacteria elicit a potent Th cytokine polarization and a cell-mediated immune response in the mouth. In this study, they took 620 participants, 399 cases of head and neck squamous cell carcinoma, 221 controls. Between the years of 1999 and 2007, the patients in the study were all over the age of 21 years. They looked at DMFT, the number of teeth with caries, fillings, crowns, endodontic treatments, and missing teeth. Now, after adjusting for age at the diagnosis of the cancer, sex, marital status, smoking status, and alcohol abuse, those that had the upper scores of dental caries, crowns, endodontic treatments, were less likely to have head and neck squamous cell carcinoma than those that had lower scores of dental caries. And I just thought that came out of the blue, and I thought that's a very interesting study. Having a lot of cavities evidently reduces your risk for head and neck squamous cell carcinoma. And last but not least, I'm going to leave you with one final study which came out in December in the Journal of Periodontal Research. If you hadn't seen this one, this was Jorgen Slotz was in this group of researchers, and they basically looked at sodium hypochlorite. People are always asking me, why do you use sodium hypochlorite? In this study, they took 30 adults with periodontal disease. They put 15 in treatment and 15 in the control. They looked at baseline at 0 and 2 weeks, and then again at 3 months. At 0 and 2 weeks, they did a 5-minute subgingival irrigation with a 0.25 sodium hypochlorite solution. The CTX4 treatment rinse ends up being a 0.20% sodium hypochlorite, so fairly close to what we're using at Carifree. The sodium hypochlorite rinse group from baseline to 3 months showed an increase of 94% plaque-free surfaces on the facial surfaces compared to 29% for the control. And the control in this, by the way, was water. I wish they'd used chlorhexidine, but they used water as a control. They had a 195% increase in the number of plaque-free lingual surfaces versus 30% for the controls. And they had a 421% increase versus 29% increase in the number of teeth with no bleeding on probing. And they probed the teeth, and then they waited for up to 30 seconds to determine whether there was any bleeding. The differences in the clinical improvement between the sodium hypochlorite rinse group and the water rinse group were statistically significant. There were no adverse effects determined by using the sodium hypochlorite other than a few minor complaints about the taste of the bleach, which comes as expected. So the conclusion was a twice-weekly oral rinse of 0.25% sodium hypochlorite produced marked decreases in dental plaque level, bacterial load in the mouth, and bleeding on probing, and may constitute a promising new approach to dental management of periodontal disease. Obviously, we're using it to treat, we're using it in our CTX4, as we use it to treat dental caries. But in this study, it significantly reduced the bacterial load. And, bacterial load is the #1 risk factor. If you go back to risk factors, after we have the disease indicators, we drop into risk factors. Invisible plaque on the teeth had the highest odds ratio. So I've run over just a little bit trying to get all this research in here for you tonight, but that gives you an update of the last year in dental caries research that I think was significant. Again, I want to thank you all for attending. I know we'll take a couple of questions here. And I know that you guys are all still on the line, so I really appreciate that. I'd like to answer a couple of questions. And again, this is my email address. If any educator would like a copy of this PowerPoint, you're welcome to it in PowerPoint format. I'll send it to you in PowerPoint, not PDF. You're welcome to it. Again, and any other individual, if you want a copy of these studies or whatever, just email me and we'll make sure we get that out to you. Based on the number of responses, it may take me a little time to get it to you, but I will get it to you as soon as possible. So, Janelle and Cody, do we have a couple of questions here tonight?
Yes, great. Thank you, Dr. Kutsch. Like you said, we have a lot of people joining us tonight, and we have some really great questions coming in. I think we have time for a few of them. So first, what are your fluoride recommendations for a high-risk child under the age of 6?
That's a great question. I think I pretty well covered that, but let's reiterate that. If I've got a high-risk kid under the age of 6, definitely going to use fluoride varnish 4 times a year. Everybody supports that. The ADA, AAPD, everybody. I would also recommend an 1,100 part per million gel or toothpaste dentifrice for the child in a very small amount. And with the understanding that you've had the conversation with the parent, that you're talking about benefit versus risk, benefit of reducing their decay rate versus the potential risk of some fluorosis of their permanent teeth. And so that's what I would recommend, and that's about it in terms of fluoride. So I hope that's pretty clear. Have the conversation with the parent, include them, help them make the decision. Let them be informed parents and make the right decision for their kid. Great question.
Thank you. In the interest of time, we'll just do one more question. That question is, how will the new research in the field of genetics affect caries treatment recommendations?
Oh, okay, so a really short question. Yeah, that's a really good question as well, and it's one I'm not sure I know the exact answer to just yet. I don't think we can anticipate just yet how the new information that we're getting, because it comes from such a broad range of sources, whether it's matrix metalloproteinases or human leukocyte antigen. How are you going to treat that? But I think the one thing that we have to be aware of, if you think that you've eliminated all the other risk factors and the patient still has dental caries, and you maybe even see a geographic appearance of the expression of the disease that matches one of the DMFTs that Schaefer and Feingold described in their paper. The one thing we know, if you've got a genetic issue at play, the one thing you need to do is support wellness as much as you can. Make sure the patient's aware of the fact that they're predisposed to this disease, and they need to limit the acid exposure. So anything that you can do to support their wellness, support the limiting of acid exposures in their mouth, that would be my approach. How will our future affect our, future discoveries? I'll tell you as it happens. But today, if I suspect, like the two patients I shared with you tonight, that for one, I'm very positive that she has a lysyl 2 deficiency because it's such a distinct geographic expression in her, and her mother also had the same disease, expression of dental caries. And the other one, I'm confident because we've eliminated pretty much every other risk factor, that I'm pretty sure that that's associated with that AJAPI1 gene. Basically, for those patients, we just need to have them be really aware of the fact that they have a genetic predisposition, and they need to take more precaution and be more careful because they're more at risk than a normal person would be. And so it's really about that pH function in the mouth. Just try and keep them as healthy as you can and limit their exposures. So I think there will be a point in time we'll actually have genetic testing that we can do in chairside. I mean, that's years away, but I see a day that we'll be doing that. Anyway, and then we'll make our recommendations as it seems appropriate. Those are great questions. Thank you, Janelle.
Yeah, thank you, Dr. Kutsch. Do you have anything else you'd like to add before we wrap up the webinar for this evening?
I just want to tell everybody that's tuned in tonight, I'm just overwhelmed by the response to this webinar tonight, and I just really appreciate and applaud your passion for this disease. It's certainly a challenge for all of us, and all of us are smarter than one of us. And so I always learn every time I spend time with any one of you talking about your patients or talking about your challenges, and that's really, this is just my mission in life, and I just appreciate you all being a part of that. So thank you all, and have a great night.
Thank you, Dr. Kutsch, and thank you to everyone. Thank you for all your great questions. Again, any questions that were not answered by Dr. Kutsch will be answered via email within the next few days. And we really appreciate your time. An email will be sent out tomorrow with a link to the recording for anyone that wants to share this webinar with their staff. And please feel free to contact us with any questions, or if you would like to learn more about implementing Canberra into your practice. Again, we do offer complimentary one-on-one webinars and would be happy to schedule one to fit into your practice's schedule.